Hello everyone, welcome back to a new episode of MemoMap. Today we move one step forward from understanding the cardiovascular physiology to apply it in a real clinical condition. In this episode, we explore two powerful challenges to the circulation, the shock and the gravity. Let's start with shock, which is defined as a failure of a tissue perfusion, and this is due to inadequate cardiac output usually, but not always. So we are going to discuss the definition and types, the compensatory mechanism and clinical manifestation, and the last but not least, the treatment and the possible outcome. So let's start. Now, let's starting with the definition and the type of the shock. The shock is defined as a state of inadequate tissue perfusion, usually due to the relative or absolute decreasing in the cardiac output. The key idea here to remember is that the tissue blood flow depends mainly on cardiac output, and shock occurs because cardiac output is truly decreased, and this is absolute reduction, or in some type of the shock, the cardiac output normal, but still the tissue is inadequate perfused, and this is a relative reduction in the cardiac output. So let's starting with the absolute or decrease in the cardiac output or the true drop in the cardiac output. Here is a problem either in the blood or the heart or in the flow between the heart and lung and the aorta. So let's start it with the hypovolemic shock. The problem occurs due to decreasing in the blood volume as in trauma, hemorrhage, surgery, or dehydration. So when we dropping the blood volume, the mean systemic filling pressures decrease, the venous return decrease, the stroke volume decrease, and the cardiac output decrease. Second type, the cardiogenic shock. Here, the problem in the heart, it's pump failure, and this could be due to damage in the muscles, myocardial damage, infarction, or damage of the electricity of the heart, the arrhythmia. And in this condition, decrease the ventricular contraction, decreasing the stroke and the cardiac output. The last type in this category of shock is the obstructive. Here the problem is that the blood flow is blocked either from heart to the lung or from the lung to the heart or from the heart to the aorta. The common example is the pulmonary embolism, the cardiac tamponade, or the aortic stenosis. And here, since we obstruct the inflow or outflow from the heart or to the heart, the cardiac output is decreased. Let's move to the second type of the shock or second category of the shock in which the cardiac output is normal but tissue perfusion is inadequate. This is a relative decrease in cardiac output. The problem here is mainly in the blood vessels, and we call it the low resistance or distributive shock. The marked dilatation will dropping the total peripheral resistance, so the arterial blood pressure is dropped despite the cardiac output is normal, so the blood not effectively delivered to the tissues. The example for the distributive is the neurogenic anaphylactic with a severe allergy, and the septic due to the infection or the bacteria that affecting the vascular functions. And now let's move to compensation. And here we are going to talk about compensation of a hemorrhagic shock. And to understand this clearly, think of two main questions. What is the goal of the compensation, and how does the body achieve this goal? The goal of the compensation to maintain the blood pressures and to preserve or keep the flow to the vital organ, mainly the heart and the brain. So, to maintain the pressure and to redistribute the flow, we have two mechanisms, the rapid and slow. The rapid compensatory mechanism immediately immediate mechanism to maintain the blood and pressure and to restoring the or redistribution for the blood flow, and this is achieved by the dropping of blood pressures will result in decreasing the discharging from 2 receptor pyro ATS stretching and increasing the peripheral chemoreceptor. If you want to learn more about this, refer or go back to the MemoMap of blood pressures regulation. The result of this is the activation of the vasomotor with activation of the sympathetic, and this will result in increase the heart rate, the contractility, the vasoconstriction of the artery and of the vein. So to maintain the pressure and redirect the flow or the blood to the vital organ. The hormonal, which is the slow, is mediated mainly by activation of the sympathetic, which resulting in change in certain hormone, which are the calf hormone. And if you want to know more about them, refer to the videos regarding the MemoMap for the regulation of the diameter of the arteriole. What are these hormones? The catecholamine from the adrenal medulla, the renin-angiotensin from the kidney, and the vasopressin. And this will producing a vasoconstrict by angiotensin to and catecholamine, as well as the vasopressin, salt and the water retention by the catecholamine, sorry, by the renin-angiotensin vasopressin mainly, sorry, and the water reabsorption by the vasopressin and stimulation of the thirst. So the keeping the resistance and also keeping the blood volume. And it's moving from the rapid to the slow compensation. And here the aim is to restoring the blood volume, and we have plasma volume, plasma protein, and the RBCs. For the plasma volume, to keep the plasma volume or restoring the plasma volume, we have three mechanisms. Either the fluid shift phenomena from the capillary, which depending on the hydrostatic pressures, the thirst sensation, or the hormone which act on the kidney, mainly the vasopressin and the aldosterone. For the plasma protein, and here we mainly focusing on the albumin because it is the essential to maintain the oncotic and keeping the fluid inside the circulation. And for reduced albumin, all what we need to do or what body need to do to release the stored albumin or sensitize a new albumin from the liver. Last but not least, the red blood cells. Here we increasing the number of RBCs through the stimulation of the erythropoietin. Now let's move to the manifestation of the shock and more important why they occur. And we're starting from the head to the kidney. So first, the brain. The patient may present with restlessness and the disturbance of the consciousness. Why this occurs? The restlessness is due to sympathetic activation of the RAS system. The altered consciousness mainly due to the dropping of the blood pressure and perfusion of the brain. Move to the cardiovascular manifestation. By examining of the pulse, we found increasing in the heart rate, dropping of pulse pressures, and cold pale skin. Why? Due to the sympathetic, with increase in the heart rate, the vasoconstrict causing a coldness and pallor due to the dropping of the blood flow. And the narrow pulse pressure is mainly to the dropping of the stroke volume. The blood pressure is dropped, and this will decrease the perfusion to the tissue and shift to anaerobic metabolism, resulting in metabolic acidosis. And respiration, there is increasing respiratory rate due to the stimulation of peripheral chemoreceptor. Last but not least, the urine, the renal system. There is dropping of the urine output due to activation of the catechol RAS system and vasopressin, the only hormone which decreased and resulting in dropping of the urine output, either dropping in the right atrial natriuretic peptide. And to know more about these hormones, go back to the regulation of the blood pressures. Now, what about the treatment and the outcome of the shock? For the treatment, the aim here are two: remove the cause and restore the adequate tissues perfusion. How we are restoring the perfusion? Either restoring the volume by transfusion, either from whole blood, plasma, or a volume expanding. So just improve the circulatory volume to improve the venous return. or support the vascular tone or the cardiac muscle, supporting the vascular tone by using the vasopressors to increase the peripheral resistance, or improving the cardiac muscle by using the inotrope to improve the contractility and cardiac output. Additional therapy that could be used in some type of the shock is the corticosteroid. What about the outcome of the shock? Either the patient recover or died, or a third possibility is the refractory or reversible shock. So let's focus about the refractory shock. What is the refractory shock? Refractory shock means that the shock not respond to the treatment even after restoring the volume, even after treatment of the cause. Why does this happen? We have two major mechanisms. Either the capillary failure and leakage of the fluid from the capillary, or positive feedback. Starting with the capillary failure and leakage, and here we have three main causes: the precapillary venule dysfunction, or the precapillary spasms, the precapillary and venular spasms. Here, the blood enter to the capillary from the arteriole, but is not able to move from the capillary due to the constriction of the venule. So, the hydrostatic in capillary increase and filtration increase. The fluid move from the circulation. The second cause, it's also related to the capillary and cause capillary leak, is the granulocyte activation with the release of reactive oxygen species. Here, the reactive oxygen species damages the capillary as well as the tissue, increasing the permeability of the capillary, allowing the fluid to move from the blood to the tissue. Last but not least, the bacterial translocation from the GIT, causing more vascular damages. Now let's talk about the positive feedback or the vicious circle, and here we have two feedback, for one for vasomotor, responsible for the vasomotor failures, the cerebral ischemia affecting the vasomotor, decreasing the sympathetic output, decreasing the cardiac output, so more dropping in the blood pressure, more ischemia to the vasomotor. And the cardiac failure, the cardiac ischemia, resulting in dropping of the damage of the muscle, cardiac muscle, decreasing of the contractility, and decreasing the cardiac output, resulting in more dropping of the blood to the heart and more myocardial damage. Now, let's talk about the gravity. After we finish the shock, the important physiological challenge is the gravity. And here, what happened when the person move from lying to standing position? The first effect, that the blood will fall in the lower limb. This increases hydrostatic pressure in the lower capillary, increasing the capillary filtration. This will result in dropping in the mean-systemic filling pressures, the venous return, the cardiac output, and the blood pressures. Normally, the body compensate. What is the compensation? The dropping of blood pressures will result in decreasing the baroreceptor firing. This activates the vasomotor and sympathetic activity, resulting in increasing the heart rate, contractility, and vasoconstrict of the arteriole to increase total peripheral resistance, vasoconstrict of the vein to increase the venous return, so restoring the blood pressure back to the normal within a second. But what happens if the compensation fails? If this response is insufficient, the blood pressure remains low, the cerebral perfusion decrease, and the person feel dizziness and fainting, and this is what is called orthostatic hypotension. When does this occur? Mainly if sympathetic activation is weak, or there is a sympathetic neuropathy, as in diabetic, autonomic nervous failure, the problem in the vasomotor center, or due to administration of the sympatholytic drugs. Now let's recap together everything we covered today in MemoMap. We started by the shock. We talked about the definition: inadequate perfusion due to inadequate cardiac output. Then we talked about the type and the cause, whether due to blood volume, hypovolemic heart, cardiogenic blood flow, obstructive, or blood vessel vasodilate, which is distributive. Then we talked about the compensation. We explore the rapid compensatory, which are neuron and hormonal. For neuronal, we have three: baro, stretch receptor, and chemoreceptor. For hormonal, we have three: catechol, RAS, and vasopressin. Then for the slow compensation, aim to restore the plasma volume or albumin or the RBCs. Regarding the manifestation, we connect the physiology to the clinical side. We talked about the brain, restlessness, unconsciousness, the heart, rapid and weak pulse, the skin cold and pale, pressures decrease, respiration increase, and urine output decrease. Then we talked about the treatment, either to remove the cause or restore the perfusions, and the outcome: recovery, death, or refractory. The refractory persisting of the shock despite the treatment, either due to capillary leak or positive feedback from from the heart ischemia or the brain ischemia. Then we talked about the gravity when moving from lying to standing, the blood pool, and this decreases venous return cardiac output pressure. The compensation by photoreceptor activation, increasing sympathetic and heart rate contractility. If the compensation fail, this will result in orthostatic hypotension, dyspnea, and fitness. That's for today, MemoMap, and see you in next episode.